Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. We have a very complex case here of a patient who was referred to me by another colleague. And so I'll give you a brief case history and background whilst you're watching the beginning of this video. So this patient visited a colleague of mine with impacted earwax. And from what I gathered, my colleague was able to remove a tremendous amount of earwax from this patient's ear, but they just struggled with this residual wax on their eardrum, and they invited the patient back after, I think, a week. They had been told to use some hydrogen peroxide drops, and my colleague again attempted to remove this. I think they used a combination of microsuction, what we're doing right now, and also irrigation, but this wax just wasn't budging. And this patient was experiencing not only reduced hearing and all the symptoms we typically associate with impacted earwax, which is a fullness in your ear, block sensation, but also tinnitus. So tinnitus can be described as a sound that originates either within inside your ears or inside of your head. That's not due to an external, it's not an external sound essentially that you're hearing, it's an internal sound. And with this particular wax, when I first examined it, I thought it would be pretty straightforward. I thought I'm going to get access to this quite easily and it will come away. But three things I would say, made this case quite challenging. First of all, you may have seen, just before I put the drops, and I've just put some drops in now, that as soon as I made contact with this wax, the patient did flinch a little bit. They didn't find it uncomfortable, they just said they could feel the wax trying to come away from the eardrum, and that just it's an involuntary reflex on their part where they twitch. So it wasn't uncomfortable, but they could feel that. So I've got to bear that in mind now when I'm trying to remove this wax off the eardrum. I've got to be prepared for the patient to again possibly flinch again. Secondly, the use of hydrogen peroxide drops, I sometimes feel, and it's a personal thing, just anecdotal. Anecdotally, I've found that hydrogen peroxide drops, yes, it does break up the wax, but it can make the consistency very difficult to remove. And thirdly, one of the risks of ear irrigation or syringing, it can jet wash or propel this wax right up against the eardrum. And I think there's a combination of the latter two there. So because this wax is really stuck on the drum, wax shouldn't really be on this part of the ear canal. Generally, wax is secreted on the outer third of the ear canal. You may get some wax that travels a bit deeper into the ear, but when you've got wax like this that's stuck on the drum, it's either the patient's been pushing in their ear, which again is another possibility, and they've used a Q-tip, cotton bud, and they've squashed this in the ear. Now, they said they didn't do it, but that's one plausible. So if you ever see a patient with wax on the eardrum, that's something that you've got to ask yourself. But again, one of the risks with ear irrigation or syringing is the concept of ear irrigation and syringing is to flush the wax out. So you pump water into the ear, normally, hopefully up against the side of the ear canal walls. And the concept is that this wax travels around the edge of the ear canal and it fills up towards the eardrum, and then you get the backflow, the water starts to coming out. And as the water comes out, any wax in the ear canal also does too. But sometimes, and it's just an unfortunate thing, sometimes when you use water to flush out wax, you can actually propel, jet wash the wax right up against the eardrum. So for those two reasons, it's really, really difficult. I'm just using the fine end. Ideally, the full Zollner suction probe would have been a bit better for me because I needed that additional suction, but I just felt the patient would have tolerated it, so I just decided to just use the fine end, and it's going to be a long procedure. So in total, it took me 20 minutes of time within the ear. That doesn't. You've got to factor in the times I came out to clean the lens of the endoscope, to unblock the suction probe, to instill drops in the ear. So in total, the patient was actually at the clinic for about 40 minutes, 45 minutes, and our slots are actually half-an-hour slots, and it's very seldom and rare that a procedure can last more than half an hour, even the most complex one. But this is just one ear as well, and it did take a long, long time. And because it is on the eardrum, we've just got to be really, really careful with this sucker. If I force the suction probe or embed it too deep into the wax, there's always a possibility of making contact with the eardrum and even perforating it, which is the last thing we want. So I am making slow but steady progress, and I've used a combination of olive oil drops initially. I don't think the olive oil really did much, so I'm now using sodium bicarbonate drops. Now, if I was going to recommend, just say olive oil drops is not suitable for the condition, but sometimes it's not. There's a lot of high keratin content, a lot of dead skin content. Olive oil is not really going to do too much. So, for example, if you've got a patient who attends with keratosis obturans, for anyone who doesn't know what keratosis obturans is, I've got a playlist on my YouTube channel where you can watch a number of cases, and in there I detail what a keratosis obturan is in quite some detail, but it's essentially a dead skin plug that forms in the ear. So it's not earwax, it's purely dead skin. And for that, olive oil doesn't really do much with dead skin, and I would recommend sodium bicarbonate drops in that sense, as opposed to hydrogen peroxide. I just think, although hydrogen peroxide drops does break up the wax, so when you introduce hydrogen peroxide into the ear, it reacts with a certain enzyme that's secreted by the ceremonous gland in the ear. I think it's called perinase, but it's essentially a catalase reaction, and that releases and liberates oxygen within the ear, and that liberation of oxygen, we call that effervescence. We get a bubbling, foaming action, and it's believed that this foaming action helps to break up earwax mechanically. In addition, hydrogen peroxide, breaks down into water, and the water is absorbed by skin. So a lot of earwax does contain skin, around 50% or even a bit slightly higher, and when the dead skin absorbs the water from the hydrogen peroxide drops, it swells and it fragments, it bursts, it breaks up and bursts the little dead skin cells that are exfoliated dead skin cells in the ear that almost form earwax. So again, it breaks it up. It doesn't dissolve wax though. So I'm very careful to not use the word dissolve, because that would imply that the wax disappears, but it doesn't. It's still in the ear, but it becomes very mushy. So it becomes mush because the skin is all broken up, and sometimes hydrogen peroxide drops, you can get some that contains urea, and urea also has this softening effect, so it really makes dead skin very mushy and very hard to remove. Now at this stage I thought, eureka, I've managed to start peeling some away, and I thought, brilliant, I'm going to manage to build, now that I've peeled this away from the eardrum, all the rest of it's going to peel away in large pieces. So I was half expecting us to finish very quickly at this stage, because I made that breakthrough, but unfortunately it was only that and this piece that did peel away. The rest of it I just had to bit by bit, slowly, just remove this now. Just a pre-warning at the end of the video, I'm not going to remove every little speck of wax, it's just not possible. I'll come back to it in a moment. So here I've removed enough wax to reveal a retraction of the eardrum, so I can see the hammer bone, well, the top part of the hammer bone, that little spherical shaped object, the top, we call that it's got a couple of names, the short process or the lateral process of the hammer bone. So the hammer bone is also known as the malleus, and this is the patient's left ear. So if the patient's eardrum is sucked in, we can have what we call a posterior superior retraction. So let me just explain that in a bit more detail. I've got loads of time, it's quite a long video, and whilst I'm explaining it, you're just going to watch me. You can see how close up we are. We're right up against the eardrum. I'm trying to suction this away, but it's not fully coming away because of the consistency of the wax and because it's jet washed. And also you will get a lot of staining, so even though when you remove the wax, you're going to get some of that sticky wetness of the wax that remains on to the drum. So the cavity behind the eardrum, so behind this eardrum, we have what we call the middle ear. The middle ear should be full of air, and the air pressure behind the eardrum should be the same, or ideally be the same as the air pressure in the ear canal, so the atmosphere. When the air pressure is the same or equal either side of the eardrum, that's when the eardrum is at its most mobile. So when sound waves hit the eardrum, that's when the eardrum is going to vibrate the most, when the air pressure either side is equal. So what regulates the air pressure behind the eardrum is a tube called the Eustachian tube. It's a narrow tube orifice that connects the middle ear to the back of the nose, the nasopharynx. The Eustachian tube at normal resting state is actually shut, but during the course of the day, without us even knowing or realising, when we swallow, yawn or chew, the muscles either side of the Eustachian tube, where it connects at the back of the nose, they contract. It causes the Eustachian tube to momentarily open, and then the air pressure can equalise. So if there's not enough air pressure behind the eardrum, air can travel up the Eustachian tube to increase the air pressure behind the eardrum, or if there's too much air behind the eardrum, the air can release and escape. In addition, the Eustachian tube is a drain pipe, so any fluid that accumulates behind the eardrum, it can drain out of the Eustachian tube and out of via the back of the nose. Now, if the Eustachian tube, for whatever reason, doesn't open when it should, then it means that air can't enter the middle ear space. So it can't equalise the middle ear pressure. And so what then happens is a shortage of air in the middle ear, and any remaining air gets absorbed by the cells in the middle ear, which means there's a vacuum created, so there's negative pressure. And when you've got a vacuum or negative pressure behind the eardrum gets pulled in. We've all experienced, as I'm sure, when you've got a cold, for example, so when you've got a cold, you get congestion at the back of the nose or inflammation or mucus, it can block the Eustachian tube. Or when we fly, when we descend on the aircraft, on an aeroplane, and especially if you descend suddenly, the air pressure in the cabin, so the cabin air pressure in the plane is far greater than the air pressure behind the eardrum in the middle ear. So the eardrum naturally gets pushed in, it buckles in. And then quite often we have to close our mouth, pinch your nose and blow. We call that the Valsalva, or close our mouth, pinch your nose and swallow. And that's called the Toynbee manoeuvre. And that helps to open up the Eustachian tube so the air pressure can equalise itself again. But if the Eustachian tube doesn't open, so if you've got a cold, for example, or it could be that the muscles are weakened or paralysed so they don't contract, or there's an obstruction, so there's a nasal polyp, for example, or inflammation like rhinitis or sinusitis, or the patient's just born with a narrow Eustachian tube, so it's an anatomical problem since birth. The eardrum gets sucked in, and you can see here the eardrum is sucked in. Now when it gets sucked in, the eardrum normally gets sucked in the top part of the eardrum. We call that the pars lucida, and that's because the eardrum is made up of three membranes. So the outer membrane that's facing us right now that we can see is made up of the same skin that lines the ear canal, the epithelial layer of skin. The innermost membrane is called the mucosa, and the mucosa is similar to the skin that lines the inside of our nose. I'm led to believe the mucosa in the middle ear is slightly different, but the concept is the same. So it's a sticky secretory membrane. And then there's a middle membrane, and that's a fibrous tissue membrane. Fibrous and connective tissue membrane, that's the middle membrane. And that's what gives the eardrum its strength and rigidity. However, the middle membrane at the top of the eardrum, those fibrous tissues more diffused. It's not aligned in the same way it lines the main body of the eardrum, what we call the pars tensa. So that creates a thinning of the top part of the eardrum, the pars lucida, compared to the pars tensa. And so when the eardrum is thinner, naturally it's going to get pulled in first, because it's got less resistance, that fibrous layer that gives the eardrum its strength and rigidity. It's diffuse, arranged within the middle membrane, so the eardrum naturally is a bit thinner, a bit weaker, not as tense as the remainder of the eardrum. So anything really above that short process of the hammer bone, as you can see there, anything above that is what we call the pars lucida. Now you can further separate the pars lucida, so that wax you can see there and just the top of it, we call that the attic. So that's right at the top of the pars lucida. Earlier I labelled it just to the right. You can see on the right hand side where it's clear, I've managed to remove that. We call that the posterior superior attic retraction. So when in terms of the left ear, which is what we're in now, posterior means to the left, so to the back, which would be to the right, sorry, let me just clarify that. So posterior means, in the case of the left ear, to the back of the eardrum, which is to the right, and superior to the top. You can see the eardrum sucked in that region as well. And it's created a pocket, there's a pocket there. And normally, that's the area that we're most concerned with when we're working in the ear, because that retraction pocket can sometimes cause a buildup of skin. Now, the eardrum and the ear canal, as we said, it's lined with a layer of skin, and this outer layer of skin, called the epidermis or epithelial layer of skin, that part of the skin is the portion of the skin that dies and sheds, and it's replaced by another layer of skin. And it's a continuous cycle. And the skin in the ear canal has evolved over millennia to naturally migrate out of the ear. If you have dead skin on your scalp or your arm or your face or your body, this skin, as it dies, we call that dying process, the process of skin being developed and dying right through its death cycle. We call that cornification. So once the skin is cornified, once it's died, any other part of the body, it will naturally just come off the body, whether through friction, so when you're bathing or when you put your clothes on, for example. But in the ear, it's a different story, because if this skin just fell and died and dropped in the ear, how does it escape? The ears would be full of skin all the time. So the ear has evolved, so as the skin dies and sheds, it naturally migrates. It moves sideways out of the ear like a conveyor belt. And that migration starts from the middle of the eardrum. So think about the eardrum like a pond, and at the centre of the pond, you drop a pebble, and you'll have those ripple effects, those concentric circles rippling outwards. And think about that being like skin, those ripples. This on the centre of the eardrum, the pebble drops, and that ripple effect is the skin, and the skin moves sideways, just like a ripple in a pond would, out of the eardrum, then slowly on the ear canal from the medial part of the ear canal near the eardrum right out to the entrance. And that shedding of the skin, that migration process for the skin to escape out of the ear, can take between, it can be 1.5 mil to 3 mil a month. And you can always compare that to the rate of our fingernails grow. So it's very similar in the growth rate of our fingernails. So when you've got a retraction pocket, I thought, why did I explain that? The reason being, I'm coming back to my point about the posterior superior retraction pocket. Skin, as it's migrating, can fall in there and get trapped. And that skin can then collect and form a plug, and we call that a cholesteatoma. The cholesteatoma can get bigger and bigger, and it can grow inwards into the middle ear. So it can breach the eardrum, it can perforate the eardrum, it can breach it. Sometimes it just pushes the eardrum in, so it doesn't breach the eardrum, but it just goes inwards. Then it goes upwards towards the brain potentially. It can also grow towards the back of the ear, called the mastoid. And so into the antrum, we call that region. So again, this is the patient's left ear. Imagine we're going through the eardrum, and then to the right, and then right again. That's the entrance to the mastoid bone. So the mastoid bone is the bone behind your ear. You can actually feel it. So if you get your finger, go behind your pinna, so the flap of cartilage, the satellite dish on the outside part of your ear. If you feel the bone behind that flap of skin, we call that the mastoid bone. So that's the bone behind the ear. So the bone that forms the ear canal is called the temporal bone, and the bone behind the temporal bone, so behind the ear canal, we call that the mastoid bone. And the mastoid bone is like a honeycomb structure. It's got air pockets in there, so it can easily absorb fluid. And that the entrance to the mastoid bone from via the middle ear, if you go through the eardrum, a quick right and a quick right again, and that's the entrance to the mastoid bone. We call that the antrum, antral, or antrum, different names, you can pronounce it differently. So the antral region. So the cholesteatoma can form in there. The cholesteatoma can actually then invade the mastoid bone, so it can cause mastoiditis, which is a very serious condition if left untreated. It can grow upwards towards the brain. It can breach the dura, the meninges, so the membrane around the brain, causing meningitis or brain abscess. It can also start to erode the ossicles, the three bones in the middle ear, so it can lead to a hearing loss. The cholesteatoma can also start to erode the bone that encases the organ of balance itself, so we call that the semicircular canals, and that's encased in bone, and it can disease the bone, erode the bone, and start doing damage inside the organ of balance. It can cause vertigo. The facial nerve, so that's the seventh cranial nerve. It runs behind the eardrum, where, closely where what we call the oval window is. So the third bone of the three bones in the ear, the stapes bone, is attached to the cochlea, and it's a region called the oval window, and that's where a facial nerve travels through. So it can also cause problems to the facial nerve, and when it does, it can cause what we call Bell's palsy, so facial numbness, paralysis on one side. You might have seen at the end there's a bit at the top. I just physically could not get my sucker in, so we left that, but the patient was delighted. They could hear much better. We've given them treatment for Eustachian tube dysfunction, so I did confirm that with a test. Well, I hope you enjoyed that video, guys. Take care, keep well.